For those of you who don't know me, I'm Dr. Vance Shaw. I'm the medical director here at High Point Clinic, and I'm board certified in addiction medicine. And this little talk will kind of explain the disease of addiction. Of course, everybody's heard that addiction is a disease, but when it comes to actually explaining what that means, most people don't have a clue. Now, I am an assistant clinical professor at ETSU, and we teach medical students here. And when you're in medical school, you learn diseases based on two things. One is the signs and symptoms of the disease. The other is what we call the pathophysiology, or what actually causes a disease. When I give a lecture before medical students, I ask them, what are the signs and symptoms of addiction? And I've never had a med student raise their hand to tell me what that is. Then I ask them, what's the pathophysiology? What actually causes addiction? Again, I've never had a hand raised. Okay, so if it's actually a disease, we should have signs and symptoms and pathophysiology. I'll give you an example. If you have a bad gallbladder, the signs and symptoms are right upper quadrant pain and tenderness, nausea, vomiting, fever, chills, elevated white count, those types of things. The pathophysiology is you have a gallbladder, you get a stone stuck in the neck of the gallbladder, and the gallbladder becomes infected. So that's what causes it. So again, what are the signs and symptoms of this disease that we call addiction, all right? So that's what I'm going to talk about. Now, we've really had the wrong idea about addiction for over 100 years. And unfortunately, the term itself, addiction, does not describe the disease very well. You know, as we were talking about earlier, there are some other diseases in the practice of medicine that have terrible names also. One is malaria. It's Spanish malaria, means bad air. We used to think malaria was caused by swamp gas, but that name stuck. And my favorite of all time is hysterectomy, which was a treatment for hysteria to remove the uterus. Well, that's obviously an antiquated and entirely wrong term, but that term stuck too. So I'm afraid the term addiction is probably here to stay. So, you know, we'll just have to live with it. But at any rate, I'll explain what this disease actually is, and I think y'all will understand it a lot better by the time we get done. Now, one of the problems with the term addiction is we got started with another term many, many years ago that's equally bad, depression, okay? Now everybody knows what depression is, but it's not a digital thing. You're either not depressed or you're depressed. There's kind of a scale, a grade, just a gradation there. Everybody is at least a little depressed. If you watch the news at all, you're going to be a little bit depressed. The world is somewhat of a depressing place. But where do you actually cross the line from being normal to being depressed? All right? And it's kind of an artificial construct. So in addiction medicine, we don't talk about depression. We talk about happiness. And there's lots of studies looking at this. Now in addiction medicine, we have a special term for this. We call it hedonic tone. Kind of like muscle tone, or some people call it hedonic set point. It's from the same root as hedonism or happiness. And what the studies show is that people will be on a scale from like 1 to 10, all right? Most people are 7s. I'm a 7. I've got good days and bad days. In the winter, I tend to get a little depressed. In the summer, I'm a little happier. If your dog dies, you're depressed for a while, but you get over it. So my brain wants me to be 7 all the time and always tries to get me back to that normal level. That's normal for me, okay? Now, people who are 10s are people that you can wake up at 3 in the morning and they'll smile at you and say, good morning, how are you this morning? Okay, and there's not very many of them, but there are a few. And then 1s are people like, remember Eeyore from Winnie the Pooh? Guy that just walks around all the time like that, never smiles. We've all met somebody like that, somebody that you've literally never seen them smile. They've just been walking around with a frown all their life. Well, let's say Eeyore goes to his family doctor, and the family doctor says, Eeyore, you look depressed to me. And he does a depression inventory on old Eeyore, okay, and says, okay, Eeyore's depressed. Well, what is the doctor going to do with somebody who's depressed? Obviously, he's going to put him on Prozac, right? Everybody's heard of Prozac. Prozac works on a chemical in your brain called serotonin. Everybody heard of serotonin? All right, so we put Eeyore on Prozac, and lo and behold, Eeyore lives happily ever after, right? No? Okay, what percentage of people actually respond to Prozac?
30.
Very good. 30%. All right, now, if only 30% of people respond to the serotonin system, there must be something else going on in your brain. Some other chemical is responsible for being happy, right? Now that chemical is called endorphin, or there are actually a group of them, endorphins. Everybody heard of endorphins? Like the runner's high? And actually, most of the things that make us happy work through the endorphin system. Things like when you listen to your favorite music, how it makes you feel, food, sex, sleep, all of those things work through the endorphin system, okay? So, let's say Eeyore, we give him Prozac, he doesn't get better like most people do. Now, like we have a pill for the serotonin system, think we've got a pill for the endorphin system? What do you think it's called?
Okay.
Lortab. All right? So let's say Eeyore's been depressed all of his life and he takes the Lortab. In 45 minutes, he's going to wind up here. Okay? And that is going to be a life-changing event for Eeyore. All right? How many people in here remember the first pain pill they ever took? Right. It's like life-changing event. Now here's me. What do you think happens to me when I take a Lortab? Nothing. Okay? So I can't relate to you. There's a couple other problems with the term depression. One is that it's a relative term. If I tell you I'm depressed, that means I feel worse than I did a day ago, a week ago, a month ago, a year ago, all right? If I've always been depressed, do I even know I'm depressed? No, you don't, okay? So I assume, and I've only lived in my skin, I assume that everybody feels like I do, and this person here assumes that everybody feels like they do, right? And they assume that the same thing happens when you take medication, right? If I take a Lortab or a Percocet, the only thing that happens to me is I may get a little sleepy, but that's all. I mean, there have been times in the past when I've taken pain pills and can't tell any that I've taken a pain pill except the pain gets a little bit better, okay? So they work very differently on me, okay? But like I said, they make me a little sleepy. When you all take pain pills, what happens? It boosts your energy level up, right? Revs you up, all right? So that's the opposite of the effect it has on me. So if you've lived here all of your life and just done the best that you can, you assume everybody feels like you do, but in reality, I feel like you do when you take a Percocet, okay? So you're actually having to function under a lot more of a load. Like what I explain to people is like kind of like trying to run as fast and jump as high as people like me with a 40-pound pack on your back, okay? Because you're constantly, essentially, struggling with this depression that you're struggling against to try to function, okay? But the other problem is that people like me tend to say to people like you, well, why don't you just quit taking that shit? Because we do not understand how much better a person feels when they take, essentially, something that increases their functional endorphin level, all right? So that brings us to the first sign and symptom of the disease of addiction. We call it refractory depression. Now what that means is depression that is resistant to regular antidepressants, okay? And in Europe they understand this. Has everybody heard of Ultram, Tramadol? It's kind of a crummy pain pill. In Europe, the number one reason they prescribe Ultram is as an antidepressant. Okay, so they understand this a lot better in Europe. Okay, so now I'm going to talk a little bit about the pathophysiology. Now, I assume everybody in here who suffers from this disease probably has a relative, a mother or father, who's had problems either with alcohol or opiates. It's very, very common, all right? It's very similar to type 2 diabetes. If you've got two parents that are type 2 diabetics, when you get to be 45 years old, you know what's going to happen? You're going to be a diabetic. I'm sorry, that's just the way it is, all right? So it's genetically predisposed. Now, diabetes is two entirely different types of diseases, right? With type 1 diabetes, Well, let me explain how your system is supposed to work. We have receptors on the cell. The insulin comes along, binds to the receptor on the cell, and makes the cell do certain things. With type 1 diabetes, there's no insulin. So you have to take a shot of insulin that makes the receptor work. With type 2 diabetes, there's plenty of insulin, but that receptor doesn't work very well, okay? So a lot of medicines that we use to treat type 2 diabetes make that receptor work better, all right? This is very similar to what's happening in y'all's brains. You have enough endorphins, but the endorphin receptors don't work very well. So all of the things that your endorphin receptors do, they don't do very well, okay? Now, if this binds an endorphin, it binds Percocet too. Okay, now if the receptor doesn't work very well to bind endorphins, it's not going to work very well to bind Percocets either, right? So what that means is a couple of things. One is it's going to take a whole lot more pain medicine to get you relief than it would take to get me the same amount of relief. On the average, it'll take 4 times as much pain medicine to get you the same amount of relief. So in other words, if your arm was broken, my arm was broken, I could take 1 Percocet and I'd be fine. You'd have to take 4 to get the same amount of pain relief that I would, okay? And you probably noticed that from the very beginning when you go to the doctor, you took more pain medicine than the doctor thought you would need. I've got a patient, she was 24 when she first came to see me. Both of her parents were alcoholics and opiate addicts, so she swore never to take a pain pill and never to take a drink, okay? And she didn't until she was 22 when she broke her leg. She went to an orthopedic doctor. The orthopedic doctor gave her a bottle of Percocet to last her 2 weeks. Now, she'd never had a pain pill before in her life. She ate them all in 3 days, okay? It's not tolerance. It's not that you develop tolerance to it. You're just naturally resistant to pain medicine, okay? Most people who start to come to the clinic here, and you've seen this too probably, on the average you're taking between 200 to 300 morphine milligram equivalents a day. That would kill me. They're just naturally very, very resistant to opiates. But the other thing that tends to happen is that as we get older, our endorphin levels kind of ramp up. I saw an x-ray of my dad's back when he was about 70. He had terrible arthritis in his back. And I said, "Doesn't your back hurt you all the time?" He said, "No, it doesn't bother me." So as he aged, his endorphin levels kind of ramped up over time, okay? Now, people who suffer from this disease can't do that. So about 40% of people who suffer from addiction have issues with chronic pain, okay? Because we all develop arthritis as we get older. It's just that some people feel it a whole lot more than others, okay? So the second issue with the disease of addiction is issues with pain, whether it's getting pain relief, pain control, or issues with chronic pain. All right, so does that make sense so far? Now the third thing that your endorphin system does is control your what are called circadian rhythms, your day-night cycles, okay? So what does it look like if your circadian rhythms don't work right? What it looks like is like a newborn. All right, now how does a newborn work? They sleep an hour, they're awake 3 hours. They sleep an hour, they're awake 3 hours. So most people who suffer from this disease, what will happen is they'll get sleepy about 10:30 or 11 at night. They'll go to bed, sleep about an hour, hour and a half, and wake up and they're wide awake. Okay, does that sound familiar? A lot of head nodding. So you wander around the house for 2 or 3, 4 hours until you get sleepy again. You go to bed, sleep about another hour, an hour and a half, and then you wake up again. Okay? So that's the third issue with this disease of addiction, is problems with sleep. Now, there's a disease, refractory depression, pain, and sleep. What's the name of that disease? Some people call it a non-disease. Fibromyalgia. Okay? There are other names for this disease other than addiction. Okay? Fibromyalgia is one of them. You can actually measure how well endorphins bind to the receptors in your brain. It's called receptor binding potentials. You can give a radioactively labeled carfentanil and it'll measure how well it binds to that receptor. In people who suffer from addiction, they have decreased receptor binding potentials. People who have fibromyalgia, decreased receptor binding potentials. People who have refractory depression, decreased receptor binding potentials. It's all the same disease. So the other name for this disease is chronic refractory depression, chronic pain, fibromyalgia, okay? So I was asking a group like this one day, I said,